This is also a shorter talk, and we'll be able to make it. So how do you cover stroke in 45 minutes? Ultimately, what you need to know are some of the high points, things that are going to be pretty easy points to be able to answer on the test. We're going to talk about these types of things, so let's just go ahead and jump in. So if you look at some of the most recent data for which stroke statistics are available, and I actually just checked this about a month ago, and they still are using a lot of the 2016 stroke statistics. Stroke is the 5th cause of death. When I finished residency training, so many years ago, it was the number 3rd cause of death. And other causes have actually increased, which also means that people are living with their stroke deficits. So it sort of has meant a lot of chronic adaptation. 795,000 strokes in the US per year. About 610,000 of these are first or new time strokes. And about 1 in 4 are actually people who have already had a previous stroke who are having recurrent stroke. 130,000 people die every year from stroke. 3 out of 4 patients will survive, but most have deficits. About 1 out of 3 stroke survivors will have a second stroke within 5 years. Every 40 seconds in the United States, someone experiences a stroke. Every 3 minutes and 45 seconds, someone dies. If you look at everyone in the United States who's dying, 1 out of 19 people will die just from a stroke. $33 billion cost annually. Number 1 reason why people become permanently disabled. The risk for stroke in black people is almost twice that of white people. Stroke kills more than twice as many American women every year as breast cancer. Nearly 3 out of 4 of all strokes occur in people over the age of 65. The risk of having a stroke more than doubles each decade after the age of 55. The impact of stroke will likely grow in the next 40 years, due mainly to the aging population and improved treatment of heart disease, and I would add cancer. The medical costs of stroke are expected to triple by 2030 due to the aging population, especially all the baby boomers born after World War II. We can skip this. This is kind of low yield. The point here is that time is brain. If you wait longer to have treatment, especially with acute tissue plasminogen activator, clot-busting drug, the benefits decrease and the risk of bleeding actually increases. A little bit more about the racial disparity. So black people are also more likely to suffer extensive physical impairments or neurological deficits compared to other racial groups. Black people are also twice as likely to die from a stroke than white people. Some of this could be explained by some of the incidence of risk factors, but it's only a partial explanation. So a higher chance of hypertension, diabetes, obesity, smoking rates are higher. Sickle cell anemia is another possibility. But Mexican Americans, specifically, not all Latinos, but specifically studying Mexican Americans, are at an increased risk for all types of stroke and TIA at younger ages than non-Latino people. But specifically, Spanish-speaking Latino people are less likely to know about stroke symptoms than English-speaking Latino people, black people, and white people when they've actually done neuroepidemiological studies. As far as stroke recovery, 10% of stroke survivors recover almost completely. Read another way, 90% of people still have persistent deficits. 25% recover with minor impairments. 40% require moderate to severe, or they require special care because of moderate to severe impairments. And 10% require care within either a skilled care or other long-term care facility. These are people who change where they live. They're not just there getting 4 to 6 weeks of skilled rehab and going home. 15% die shortly after the stroke. That's often within the first month, so it's not right away. It can be due to other complications like superimposed sepsis or aspiration pneumonia or even bladder infections. People can develop blood clots acutely due to acquired hypercoagulability. People can even develop bed sores from immobility and die. DVT-PE also. So definition of a TIA. So we've all heard the less than 24 hours of neurological deficits, but really TIAs are 5 to 15 minutes. But Dr. Muhammad, my TIA lasted 20 minutes. Okay. But Dr. Muhammad, my TIA lasted 30 minutes. Okay. But once you start to get beyond an hour or an hour and a half, that's long enough time that some cells will die, and we actually see a lot of this on MRIs. So it's great that you made a full recovery in 3 hours. That would be the best stroke ever. But it's still a stroke, and the MRI will often show an abnormality. So these 24-hour definitions are sort of becoming old school. Usually it's temporary blood flow to the brain that actually causes cell death. A TIA is basically a warning sign. If you make a full recovery and it only lasted 5, 10, 15 minutes, then you're much more likely to have a higher stroke. So steps should be taken immediately to prevent a stroke. And the risk of a serious stroke within the first year is as high as 10%. But even within the first 2 days, up to 50% of people could have a stroke. So there's a way to actually look at whether or not people are more likely sooner than later to have a stroke. And they actually look at whether your TIA has aphasia or other language deficits, whether there was motor weakness involved, whether you're over 60, whether or not you have diabetes, and whether the episodes were more than 10 minutes. Because if you have these things, you're more likely to have a stroke in the next 2 or 3 days. So they sort of triage this with a scoring system, and they can say, this is somebody we want to bring in under observation, even if they don't qualify for a full hospital admission. Get them worked up quickly, put them on antiplatelets, put them on cholesterol-lowering medicines, and then send them out, versus people who maybe are at a lower risk, but then you could have them follow up this week or next week, maybe like with a nurse practitioner or somebody to get them into like a TIA clinic the next business day, for example, and have a more timely approach. It doesn't mean you can just let them go for 3 months, but whether they need to be brought in versus it could be just in the next few days. If you look at people who have had a TIA, their next big event is more likely to be either another TIA or a stroke. But some of the same risk factors could make them more likely to have a heart attack. But in general, if you look at cardiac literature, it's the same type of thing. If you've had a heart attack, your next big event is more likely to be another heart attack, but it's also possible you could have a stroke. So we sort of use this to figure out how can we help the most people, because sometimes the management of TIA or stroke tends to be not exactly the same as heart attack. And there's sort of an 80-20 difference on where you're more likely to have. The more information we have about stroke and heart attack is that they're actually sort of different pathophysiology, and it's not exactly the same thing. This was actually a study where they had 2 phases, where they had people who were referred to a stroke clinic where they could receive their initial treatment once they actually came back to the stroke clinic, versus people who were given direct access and treatment was started on day 1. And stroke at 90 days was reduced by 80% by early treatment. This is why we don't dilly-dally or wait when we're trying to get people to lower their stroke risk. Embolic stroke actually is the type of stroke, an embolism, where you have a clot traveling to the brain. It's usually caused either by atrial fibrillation, where the turbulent blood flow makes the heart not pump effectively, so you develop clots, and these are tossed up to the brain. You can also get artery-to-artery embolism from a piece of plaque off of a carotid or off a vertebral artery going up to the brain. And so when you have a clot that's thrown from somewhere else, the deficits are usually the worst right at the beginning. And as that clot breaks down, many people improve over the next 2 or 3 days. This is as opposed to thrombotic strokes, where somebody already has narrowing in the brain, at like a high-grade stenosis intracranially, and then it doesn't take that many platelets to sort of build onto that stroke. And then these people sort of worsen or have stuttering deficits over maybe 1, 2, or 3 days. And then it can take them weeks or months before they start to have recovery. So these are sort of the 2 flavors of embolic versus thrombotic stroke. And then there's my favorite, thromboembolic stroke, because you can have a combination, right? So if you have a carotid stenosis, and you already have an intracranial blockage or stenosis, and a piece of plaque breaks off, and it's an embolus, and it throws up, and then it blocks the already narrowed thing, you can sort of have a stuttering, heaving of the clot, and have thromboembolic as well. So if you can imagine it, it can happen. Usually people are awake, it happens very suddenly, and so because these can be medium to large size strokes, depending on the size of the clot that's thrown up to the brain, the mortality rates are higher. You can have other cardiac causes besides atrial fibrillation. Some people will actually have just thrombi inside their wall because they're hypercoagulable. Some of them can have valvular disease, which can make them more likely to have an abnormal left atrium. There can be a hole in the heart, like a patent foramen ovale, or an atrial septal defect. So somebody has a DVT in their leg and it breaks off and goes up through the shunt. Then it can go from venous to arterial side and cause an arterial stroke. Atherosclerotic plaques can also be, for example, in the aorta, like aortic atheroma. That could break off and cause a stroke. Foreign materials like fat particles or fat emboli, air injected into an artery, other particulates, somebody injecting from IV drug use, and they hit an artery, for example. This could also cause an embolic stroke. So this is an example of bilateral frontal infarctions. You can see that these are small. Some of these can be bigger. If you have anterior and posterior circulation strokes, pretty tough to blame a carotid artery, which is anterior, or a vertebral artery. It's got to be something that's cardiogenic or aorta. So if you get a vignette like that, but that's probably not, just some of it is kind of reasoning through it. Thrombotic strokes are actually more common, so it's 40% of all strokes. Blood flow is blocked because of a clot that forms usually in an already narrowed artery. So if you get progressive atherosclerosis or large artery plaquing, then you have platelets adhering, and especially if people have coronary artery disease, so they've already got other circulating blood changes, and that can make them more prone to having clot formation. So you can see here, the idea here is look at this internal carotid, and then you've got this branch here, but it's literally so narrow you get this string sign. Here's another example, just a cartoon where it shows the plaque that's building up. And so this is the common carotid, this is the external carotid, this is the internal carotid supplying the brain. And so the lumen of the arterial wall starts to become so narrow that it doesn't take that many platelets to be able to come through there. This is actually a clot that